Hey everyone, this is the cardiologist's YouTube channel, and today we're going to explore Wolff-Parkinson's White Syndrome, a relatively rare but important condition affecting the heart's electrical system. Before moving on, we have a small request. Please subscribe to our channel and press the bell icon. Also, consider liking, sharing, and commenting. It helps immensely. WPW syndrome is characterized by the presence of an accessory pathway, bundle of Kent, between the atria and the ventricle. This pathway creates an abnormal circuit, allowing electrical signals to bypass the usual route through the atrioventricular node. This results in pre-excitation, or early activation of the Wolff-Purkinje system. Symptoms of WPW can vary widely, from palpitations and dizziness to fainting or even cardiac arrest. Diagnosis often involves an electrocardiogram, or ECG, which can reveal characteristic findings. ECG features of WPW syndrome are typical and include the following. 1. Short PR interval, less than 120 milliseconds. 2. Slurred upstroke of the QRS complex, better known as delta wave. And 3. Pseudo-infarct pattern. Delta wave results from slow muscle fiber to muscle fiber conduction. This ECG pattern is called the WPW pattern. In the presence of symptoms, this pattern is then termed WPW syndrome. Once the diagnosis of WPW syndrome is made, the next step is to risk stratify the patient for sudden cardiac death. Intermittent loss of pre-excitation with any of the following tests is a good prognostic indicator and is considered a low risk for sudden cardiac death. 1. 12-lead ECG, 2. Treadmill exercise test, 3. Holter monitor, and 4. Procainamide challenge. Pathway-associated arrhythmia. The accessory pathway in WPW syndrome is associated with the following arrhythmia. Atrioventricular reentrant tachycardia, AVRT, commonly occurs when the reentrant circuit is formed through the accessory pathway. This is either orthodromic AVRT, in which the impulse goes down the AV node and up the accessory pathway, or antidromic AVRT, in which the impulse goes down the accessory pathway and up the AV node. Atrial fibrillation and WPW syndrome. The characteristic findings include irregularly irregular rhythm with QRS morphology that varies with each beat. Atrial fibrillation or atrial flutter that is conducted through the accessory pathway can degenerate into ventricular fibrillation. AV nodal blockers and WPW. AV nodal blocking agents such as verapamil, digoxin, or adenosine can increase the conduction through the accessory pathway and can increase the risk of ventricular fibrillation in WPW syndrome and the presence of atrial fibrillation. Treatment of WPW syndrome. Catheter ablation of the accessory pathway is the definitive treatment of WPW syndrome. In the acute setting, use the following approach to treat these patients. 1. Treat orthodromic AVRT with vagal maneuvers, adenosine, beta blockers, or verapamil. 2. Antidromic AVRT is treated with procainamide. 3. Atrial fibrillation is treated with procainamide or DC cardioversion when hemodynamically unstable. As already mentioned, avoid AV nodal blocking agents in patients with atrial fibrillation and WPW syndrome. Remember that Ebstein's anomaly is the most common congenital heart disease associated with WPW syndrome. Thanks for watching this video. More videos are coming, so make sure that you are subscribed to our channel. Please support our work by subscribing to the channel.